some folks who are logged in as a group too, so want to make sure that everyone is able to take advantage of the full hour here, and we're just really thrilled that you're here with us today. I'm Kim Workmeister. I'm the Clinical Improvement Educator with the CalHEN 2.0 with HQI, and today we're going to be taking a look at a topic that I think has proved to be quite elusive to just about every hospital across the country, to be honest with you. It's a really difficult one for us to tackle, but a very important one at that too. So today we're going to be talking about reduction of harm from adverse drug events and looking a lot deeper into what we can learn from our data. Because before we know where to even be, what kind of improvements we can be making, we have to know where we are and be able to use that data appropriately for us. So today we have two speakers, and I'm just so thrilled that you're here and are going to be able to hear from them today. So first off, Dr. Medell Griggs, who is the Senior Medical Director of Quality at MLK, Martin Luther King Community Hospital, is going to be sharing with us for a short period of time about their hospital's process towards success in this area. And you'll hear some ways that they are using technology simply and effectively to be able to make improvements, and then other things that they have put in place too for improvement. And then for the rest of our hour, you're going to hear from Mary Andras, who is the Executive Director for Medication Safety and Quality at Health Services Advisory Group, or you've also heard them called HSAG. And you know that we partner with them in the state, and Mary is the utmost expert in the prevention of adverse drug events. So I'm just thrilled that they are both here. Today, our objectives on this call is to first and foremost describe the national and CalHEN progress towards reduction of adverse drug events. What have we done so far in this HEN 2.0 sprint that we're all on here? We're going to talk about some solutions for obtaining current and actionable data on ADEs, and I think that the key term there is actionable. Just collecting data doesn't necessarily help us if we can't do anything with it. And then we're going to, of course, be identifying successful best practices in reducing ADEs from peer organizations, and that includes not just our featured hospital story today, but that's all of you too. And I hope that you will feel empowered and open enough to be able to use the chat box here and type in, be interactive, share what it is that you are doing as we're working towards the end of this sprint here that's coming up very quickly in just a couple of months for HEN 2.0. Now, first, though, we want to make sure that we're all on the same page and what we actually mean by adverse drug event. And I know it seems a little elementary, but we do need to make sure that we're on the same page. And we are using the AHRQ definition of an adverse drug event being any injury resulting from medical care involving medication use. And in the HEN work, we have broken it down into three categories. That's harm from anticoagulant use, harm from insulin agents, and harm from opioids. So and I know that hospitals are only asked to submit data on one of those three, but you're likely working on all three of them too. There are lots of places to find this data, and there's definitely ways to do it that would make it very difficult to weed through, that is very involved, but that's not what we're asking. We are really asking for the data that you are looking for and using to come up with practical solutions is simple. And what we're talking about here is really the difference between data for research and then data for quality and patient safety. My husband works for, I'll put in quotes, evil big pharma, which I don't believe, but and he's in research there. He spends, a minimum of 5 years looking at ADE data that is very, very specific and very different from the kind of data that we are looking at when we talk about ADEs. We can't wait 5 years for perfect data in order to help save patient lives. We just can't. And the other ways that we find the data is we have to go look for it. This, for the most part, isn't the kind of data that is going to be easily reported through our incident reporting systems. We have to have triggers that identify that something may have occurred, and let's go take a look. Doesn't mean that those triggers mean that for sure an ADE occurred, but let's go take a look. And first, finally, we know that, really if we're making it too difficult to find, then we're working too hard. So what can we do? And we're going to talk about that today a little bit more in depth. But first on here, if we talk about just in the warfarin, the anticoagulant piece, when we're, for the purposes of the HEN, when we are looking for that data, we are simply looking at patients with a high INR. I know that there are hospitals that feel very strongly about the fact that CMS has not chosen a specific INR for hospitals to use as the cutoff point for when it counts as an ADE or not, and understood, and we'll see as they go forward with this if CMS makes a change to that. But for right now, it's whatever your hospital has defined as a high INR. Maybe it's 5, maybe it's 6, who knows what you're using. Whatever you're using, continue to use that and count the number of patients with that high INR and just assume that those patients are on warfarin, because how many of those patients with a high INR are not on warfarin? It's a very small number. Again, data for quality, not data for research. Make it easy for you. And then get a count from pharmacy of all the patients with warfarin orders, and then that's your denominator. So number of patients with high INR over number of patients with warfarin orders. As long as your definition is consistent, it can be as simple as that. Trying to find opioid data. Count all the patients who receive Narcan. Now, maybe you're going to exclude patients from the ED, totally fine, but however you have defined it in your organization, continue that way. So you're continuing to track your own progress against your own progress. This isn't, we aren't looking at data, hospital versus hospital in this work here. This is, all over aggregate, and it's one hospital comparing their improvement to themselves. So count all patients who received Narcan over all patients who received opioids. Again, how many patients who received Narcan are not on opioids, unless you're counting those ED patients who may have come in as an overdose, which most hospitals are not counting. When it comes to the ADEs related to insulin, get a count. How many patients, and that's usually from labs, how many patients had a glucose of less than 50? And do that over all patients who received insulin. Another report from pharmacy, too. Again, how many patients in-house have a glucose of less than 50 who are not on insulin? Probably a small number. If you're finding it's a larger number, okay, change the way that you're looking at it and delve a little bit deeper into this. But we're just trying to show what some of the easier ways to find this data is, so it's the least burdensome possible here. So what our improvement looks like now, though, across all of our hospitals, again, knowing that this is aggregate data that is not comparing hospital to hospital, this is just all of us as a whole, there's not a lot of data yet. Part of that probably because, hospitals only need to choose one of the 3, and that's fine. But this is a little bit difficult to see, because I know it's a little bit smaller here. But we have 176 hospitals that were eligible at the time of baseline data here. And of those 176, when we look at the data for excessive anticoagulation with warfarin, we had a baseline, we had about 47% of those hospitals submitted baseline data. But as we get closer to the March 2016, the last time that we have this data for right now, we're down to about 36% reporting. And as you can see, the data is pretty steady there. That red line is our data. Pretty steady. There was one big spike. Who knows what that is? And we're back down to where we were pretty steady. So hard to see without a lot of data here. So we would love it if you have this data, if you are comfortable submitting it. I think it would be very helpful for us. Then in the hypoglycemia piece, again, 176 eligible. We had about 29-30% of our hospitals that submitted baseline data, and we're now down to about 20%. And as you can see with the red line there, pretty steady. And in the last couple of months, we've definitely seen a spike. We'll need more data points to really see if this is a true trend here, but right now it looks like it's going up. So more data from hospitals would help us to identify if this is really what we're seeing. And then finally, in the ADEs due to opioids, out of 176, this one we had about 36% of hospitals submit baseline data, and you can see it's just kind of gone up and down. It might look like it's starting to trend up, but honestly it's hard to tell. We don't have enough data points yet, but as of March we only have 22% of eligible hospitals submitting this. So the real takeaway here is that we could really use more data for this, and this could help us as a whole to be able to find out, what is it looking like across the state, and also to be able to hear from you individually to find out what are you doing to make improvements. I know that there is a lot of work being done, and we want to hear from you. That's what this entire collaborative is about sharing and learning from others, and making sure that this entire patient safety arena is not a competitive sport. This is a sharing opportunity for us here so that we can learn from others. So in that vein, I would like to move us pretty quickly then into the story of improvement from MLK Community Hospital. And I'd like to pass it over to Dr. Medell Briggs. She has a wonderful story to tell. So with that, I'm going to pass it to you, Dr. Briggs. And if you need for me to advance the slides, you just let me know.
Okay, great. Thank you so much, Kim. And thank you so much also to HQI and CalHEN for allowing MLK to at least share our story about at least our journey in terms of performance improvement. So to start off, the name of my presentation, Reducing and Preventing Adverse Drug Events, with a focus specifically on opioid safety. However, many of the different models that we actually have applied to opioids, we've also tried to apply many of those same models to several of the other drug categories. To give a little bit of background about MLK, we are a startup 131-bed private not-for-profit hospital here in South Los Angeles. And in fact, we just opened our doors last May. So I say that we're a toddler hospital because we've been open for about 14 to 15 months. In terms of the patient population that we serve, our service area is made up of about 1.35 million residents, with almost half being less than the age of 44 years old, and our patient demographics actually reflect this younger age as well. About 70% of our patients are Latino, with about 23% being African American. And we do serve a lower socioeconomic status population, with about 65% of all household incomes that have 4 members or more being less than $50,000 per year. And 75% of our patients are Medi-Cal patients, with the vast majority of them actually being managed Medi-Cal. And those of you all that know the South Los Angeles area, by far, South LA has had a tradition of having some of the worst health indicators in not only Los Angeles County, but also throughout the entire state and maybe even in the country. And although we serve approximately 1.35 million residents, we have a shortage of physicians and other health professionals in this area. And we've actually calculated it, and it seems like we have a shortage of approximately 1,700 primary care as well as specialists within our 5-mile radius. So we are truly a health professional shortage area and a medically underserved area, which is why our establishment as a new hospital that's dedicated to performance improvement is so important, not only for the patients that we touch when they come into the hospital, but also for community health. So one of the great things, though, about being a brand new startup hospital is that we were able to build everything from the ground up. So we had no blueprints, no plans. We said, what are some of the things that have worked well in other hospitals, not only here locally, but throughout the country? What are some of the best practices from so many of our different quality institutes? And what can we actually put into our hospital? And so the first thing we thought about was, how do we prevent any of these adverse drug events to begin with? And one of the things that we have Cerner as our electronic health record system, and we built probably about 200 to 300 standardized physician order sets that are evidence-based. But when it comes to medications, and specifically opioids, all of the medications that are involved in each one of the power plans have a recommended starting dose, whether it is part of, let's say, a fracture power plan, or whether it's part of the anesthesiologist PACU order sets. And all of these order sets are collaboratively developed between the physicians, the Office of Quality and Performance Improvement, and also pharmacy. So pharmacy played a significant role in these initial starting doses, especially of narcotic medications in our power plans. So this next step for us was thinking about, how do we even monitor what occurs in our hospital in terms of any risks that occur, but also if we don't hear about the risks, what triggers can we actually build into our system? And also for all the participants that are taking part in this seminar, please, if you have any questions, let me know. I'm more than happy to answer questions during the presentation. So we actually do have a system-wide risk incident reporting software. We use RL Solutions, which many of you all may be familiar with. And that does allow our physicians and our staff to submit reports on any adverse drug events that occur in the hospital, whether it's due to opiate reversals, hypoglycemia treatment, or any other issue that they think needs to be reported, whether it's a true negative outcome or a near miss. And our staff and physicians are able to submit any of these events using their name or anonymously, and it directly comes to my office, the Office of Quality, where we actually review it on a daily basis. And if we do see that there's an adverse event, we immediately follow up on it. But one of the great things that I had a lot of fun with, because I'm a data nerd, is actually develop the true data analytics behind the trigger points for seeing if any adverse drug events are occurring in the hospital. So one of the things that I think is critical to at least our early success has been the presence of a clinical data analyst. And I really strongly believe that a clinical data analyst is worth their weight in diamonds, meaning somebody who is master's or PhD prepared that understands many of the large data analytic systems such as SAS or STATA that can actually build programs that go directly into your electronic health record system so that you can actually provide real-time or close to real-time surveillance of what's going on, what's being ordered in your system, what's being charted. And that's one of the things that we did. So jointly between the Office of Quality and specifically my clinical data analyst, myself, as well as pharmacy, we developed an opioid ADE surveillance code. And what the surveillance code actually does is that it runs in the background. And so when there is any administration of naloxone, so not just the ordering, but most importantly the administration, because oftentimes even in our hospital, if there's something such as moderate sedation, the physicians may actually order Narcan just to be at bedside if an adverse event does occur, but of course they do not end up administering it. So we wanted to make sure that we capture the administration of naloxone. And at that same time, if we did notice any triggers, our code actually immediately pulls out patient information, the unit where the Narcan was administered, the time administered, and the prescribing physician. And it also looks for the last dose and the types of opioids that were administered before the Narcan was administered. And how we actually developed this code is that from pharmacy, we took, of course, every single narcotic that was on our formulary and incorporated it directly into this surveillance code. And with any naloxone administration, it automatically triggers a manual medical record review, both by pharmacy, but also when we run the reporting quality, we follow directly on each one of those cases. And we do include the emergency department. I'm an emergency physician, so I can attest to actually giving and seeing patients with narcotics, and of course, different people have different levels of sensitivity. And so that's why we do a manual review, because of course if somebody presents to the emergency department and we're giving them Narcan due to an overdose, that's very different than we were actually dosing somebody in the emergency department with multiple doses of narcotics and then they went into respiratory depression. So we absolutely include the emergency department, but of course we do the manual medical record reviews. So here's a little bit of our trend of data. As I mentioned, we did just open in May, so we did not have a significant amount of baseline data. But one of the things that we noticed is that, yeah, we were starting to see at least 2 ADEs due to opioids over a couple of different months. And what we actually did is that we provided focused house-wide education, specifically through our interprofessional performance improvement committee, which is made up of all of our clinical and non-clinical directors as well as our medical directors, and told them, hey, guess what? We're taking part in CalHEN. We're now tracking ADEs in these different categories, and this is an area that we're noticing that we're starting to have some ADEs, and let's explore it. Let's make sure we understand what ADEs are, and let's try to see what we can do to actually prevent it. So during around November, when we first started rolling out some of our CalHEN data to the Interprofessional and Performance Improvement Committee, we did see a decrease down to 1 case. But we noticed that it continued and continued over the next couple of months. So we did a little bit of a deeper dive. And one of the things that I realized was that these additional doses of naloxone were actually being administered intraoperatively. So some of our anesthesiologists and CRNAs, of course when a case was ending, would give a little sprinkle of naloxone to the patient to start waking them up. And we know that we really want our anesthesiologists to sort of watch patients very critically, so when we're actually ending the case, they lighten up on the sedation. But we thought that maybe that this was a practice that maybe some of them had, but regardless, it maybe wasn't the best practice, but we wanted to engage them to see how we could actually fix it. So the second intervention was actually sitting directly down with the anesthesiology medical director and actually showing him the data. And the first thing that I said was truly just, I'm not an anesthesiologist, but is this a standard practice of actually providing Narcan to wake patients up a little bit? And if it's not, what are your thoughts about it? When I presented it to my medical director, he was completely appalled, and he said, absolutely not, we're not supposed to do this. I will take care of it. I will completely inform my entire anesthesia care team. And then as you can see, in March, April, and May, and also in June, we have not had any additional naloxone given after any of our opiates. So that for us was a pretty great success, and it was sort of provided us with a roadmap for continued physician as well as staff engagement of making sure that they are completely presented the data in a way that was not accusatory, but more of a fact-finding and seeing what we can do together. And so to that point, some of the lessons learned for us was that, number one, we need to be able to use our electronic health record system to the best of our ability and use it as a data mining tool in real time or even close to real time. We have triggers for real time that the pharmacists see, but then Office of Quality, we review it for sure on a monthly basis and do manual reviews unless there's another risk incident report that triggers us to review it immediately. In addition, spreading of any knowledge, and especially the data, to physicians and staff is something that we also think is very critical. Oftentimes physicians and staff, they may be aware of a potential adverse drug event, but they may not fully understand what leads to them. And also what some of their practices may be that actually can be defined as an ADE or contribute to an ADE. So one of the things that we really try to pride ourselves on here at MLK is not having silos. Not having silos between physicians, nurses, pharmacists, and other support staff, and for us all to talk about our performance improvement as a whole, because all the patients are our patients. And last but not least, engaging the patients, the physicians and or the staff. And my way that I've always approached this, just because as a physician, I know what it feels like when somebody comes to you about something with quality, but I always just start framing it up, I need your expertise in this area, or hey, tell me your thoughts about this, because this isn't my field and I just want to see what you think about it. And most importantly, is this your standard practice? And if it's not, or if there is a large amount of variation between your physicians in your group or the nurses on the unit, what can we do together to fix this problem? So that's sort of our journey in terms of opioid ADEs, and at least where we started, some of the interventions and the methods that we put in place. And we've done several similar things for hypoglycemia as well. So we have triggers if an AMPA D50 is provided in the hospital, and we actually do manual reviews of those items. Also, of course, if there's any other type of reversals like vitamin K or anything else, or FFP, that we may think that somebody has an extremely elevated INR, we have those same type of mechanisms that are in place. So I will open up for questions. Thank you so much.
Thank you, Dr. Brooks. And as I wait, this is Kim again, and as I wait to see if questions are chatted in, I really want to touch back on the point that you made. I mean, aside from the, exactly what you're doing to be able to use, using data triggers to mine for ADEs, I really appreciate your approach to engaging physicians and engaging other disciplines into this work. And I know it's one thing to say that we've taken silos down, but that's a really difficult thing for a lot of hospitals to do. And I think the advice that you just provided here is great. The way that we that we ask questions of our other disciplines, and especially as it comes to physicians, because I know for so many years, I know I was guilty of it for many years as a director of quality in a couple of other hospitals too, where I would just say, okay, I need you to, Dr. Smith, I need you to approve this, without having involved Dr. Smith in the decision-making before. So of course there was pushback, and that was, my wrong on there. And I learned some valuable advice from that too, and it's very similar to what you were just saying too. And I think that's if we approach any other discipline with, can you help me to improve this, just like you said, as opposed to, can you approve this? It really does help to break down those silos and let other people on the team know that their opinions are incredibly valuable. We don't just need them there to rubber stamp what we're doing. I think that's wonderful. And I do have a question for you. When you talk about this process of using triggers to find potential ADEs, and this was a great example that you gave, how much time do you think your staff is spending in this process? So there's a report that they're going through. I mean, is this really labor intensive, or is this not so bad?
The report takes about 5 minutes to generate, if that. So it is not labor intensive at all. The hardest part of this process is building your first surveillance code, and that probably will take a good 2 to 4 hours depending on your clinical data analyst skills. And it's really not building the codes, it's really gathering all the information together. And so I can tell you that my team member, she put together all of our codes probably over less than a week's time by meeting with the pharmacists, meeting with the others that she needed to get certain information from, working collaboratively with them as well in order to make sure that the code was going to be built correctly. So the investment is up front, but then after that, you literally just have your patients that had a certain medication administered, and then you go directly into the MAR, or you go directly into the clinical documentation and try to see exactly what occurred. And of course, that's just a standard chart review that my team normally, and myself, I can normally do that in less than 10 minutes. So it's not labor intensive at all, as long as you have the right code that's developed.
Wonderful, wonderful. Well, I know that you do need to drop off and go to another meeting here too, and I want to be respectful of your time. I don't see questions in the chat box right now, but at the end, if we do get other questions, I will make sure that folks have your contact information so that we can make sure to get questions answered if anything comes up in terms of report development and just really more of the ins and outs of how you do this. But Dr. Brooks, I just want to thank you so much for joining us and sharing with us and for sharing your expertise with us. And again, this is what this is all about in the HEN. So thank you for that. And with that, I am going to move on then to our next presenter, Dr. Mary Andrade. And she is going to take us through, let me go through to simplifying the approach to measurement here. So with that, Mary, I'm going to have you take it away and just make sure that you are able to advance your slides too. Otherwise, I will certainly help to do that.
Excellent. Thank you, Kim, and good afternoon, everyone. My name is Mary, and I'm very familiar with your work within CalHEN, as I used to work for CMS, and this was part of the work that I did there with the Partnership for Patients. So kudos to each one of you, because really the rubber meets the road on the very, very front line, and that's each one of you. So I wanted to really kind of just take the opportunity to talk about how to simplify this work. And so it really starts with the measurement. You already heard this from Kim and from our speaker just now, but I just wanted to kind of underscore this. Do not try to create a perfect average drug event measure or a set of measures. I think that's where I have seen most hospitals get tripped up in this work, because when you start at the very, very front of the work and you're ready to get started and you're trying to create your measure, you can really get caught up in creating a more and more perfect measure. And what we really want here is something that you can just track over time to track your improvements. And the focus should really be on the clinical care and the quality improvement side of the work. That's where you should be expending your energy and expending the intensity, and not necessarily in designing and crafting the perfect and most scientifically correct measure, or doing data collection that's just very labor intense. That's just, it shouldn't be the focus of the work. So I wanted to ask, I'm actually glad, it looks like it's kind of a small group. How many of you that are on the call now know how your hospital is doing in ADEs in each of the 3 drug classes? So adverse drug events from anticoagulation, hypoglycemia, and opioids. So maybe we can use, Kim, if it's okay, if people can use the feedback to raise your hand and let me know that you agree, or sorry, that you know how your hospital is doing in ADEs. Can you just raise your hands? I can get a count.
And to raise your hand, there's an icon at the top of the screen that you can click that looks like a person raising their hand up.
Okay, so I only see a couple of people, Kim, you're one of them, so you probably don't even count, that say that they know how they're doing. And I'm not surprised. Okay, so one more person just raised their hand. Thank you to both of you for responding. And I think that that is kind of a trend that we see in hospitals all over the country. That, well, I used to work in a hospital. I'm a pharmacist, and I never knew how we were doing in ADEs. It wasn't on any dashboard. It's not being used for any payment. It's not a joint commission measure. It's not. It was one of those things that we weren't measuring it, so we had no idea how we were doing. And I think that's just kind of important to acknowledge from the front. If we don't even know how we're doing in ADEs, that's kind of the start of the work right there. So this is my favorite quote, and I think if you remember just one thing from this presentation, this webinar, it's this kind of encouragement to just start where you are, use what you have, and do what you can. I know that your time, for example, in the CalHEN work, for example, is running short, and Kim, I don't know exactly what the clock is looking like there, but you have support from HQI and CalHEN to do this work now, and so you should take advantage of that support and the resources that are available through Kim and Lynn and her team at HQI. So I also wanted to share this message that improvement in adverse drug events is 100% totally possible. And I don't know how many of you have seen this slide. This was the analysis after what they called HEN 1.0. So most of you were probably involved, maybe, I'm not sure, in the first round of the HEN work. And now that CalHEN is continuing its work in what we call HEN 2.0. But initially, the work went on for 3 years, and this is the result of that work. So this is a change in all of the different harms that the HEN works on. The HEN provides support to the hospitals in adverse drug events, and CAUTI, and CLABSI, and falls, pressure ulcers, surgical site infections. You can see the list here. I find this alarming and shocking. Look at the one area of harm that had the greatest reduction. It's adverse drug events. There was a 40% reduction in adverse drug events during the course of the campaign, which means that hospitals all over the nation were able to start measuring their ADEs somehow, like I said, imperfect measures, that's fine, and then drive improvement in those numbers. And that's how this number, which AHRQ has a data source called the Medicare Patient Safety Monitoring System. That's the source of the data for the adverse drug event portion. And they saw a reflected 40% drop. So the work that happens in your hospital makes a difference. It makes a difference for patients whose lives are affected, their hospital stay is affected. Those are people that are mothers and fathers, brothers and sisters. I mean, it's us, right? We're all the patients. So I just wanted to kind of encourage you that you need to start somewhere, and improvement really is possible. So you're probably thinking now, okay, we're ready, we're here, we're on the webinar. Where exactly do you want us to start? And I have here a link from the Minnesota Hospital Association. They kind of took the lead for all the on behalf of all the hospital associations and created kind of a gap analysis for each of the 3 areas. So you have a place to start. So if you really are kind of starting from point 0 and want to know, like, okay, where do I get started? You can go onto their website, and each of the gap analyses is probably 2 to 4 pages long. It's not super long. It just is like a checklist. You know, do you provide education on opioid therapy? Yes or no? Or do you have a system in place to eliminate errors in storage? Yes or no? And then wherever you have a no, those are things that you can kind of use as a starting point, possibly, to drive interventions in the work. But again, this is for the intervention piece. We already talked about the measurement piece, and Kim, you covered the 3 measures perfectly. So you should all be able to get that data. It's very straightforward. You know, it's INRs that are greater than whatever. You could use 5 or you could use 6. Different hospitals use different benchmarks. And then same thing for blood sugar for hypoglycemia. It's any blood sugar reading from a point of care device that's less than 50 or 40 or 60. Again, the benchmark's not important. What's important is that you track it and then trend it over time. And then opioids, I think naloxone usage is probably the most common one I've seen there too. So we have the measures. This is where you start with the intervention. So I think once you've had a look at the gap analysis, you should be able to, what I say, or what I call, choose your adventure and go. And I'll actually give you a step-by-step a list of things to do. But before we get there, I wanted to include this tip somewhere. And it's a tip that we learned at a national level over the course of 3 years. And so I want to share that tip with you guys. Patient engagement, or having some kind of patient voice involved in your work, makes your work go a lot faster and really brings urgency to the work. So if you can find a patient in your facility that is willing to come to your meetings and be involved in the work and can speak to how dreadful it is to live through an adverse drug event, or worse, to lose a loved one because of an adverse drug event, or to have some kind of other permanent disability because of one of these preventable events, it really brings passion and urgency to the work, because you realize that could have been me, that could have been my family, it could have been, you know, my child or my spouse. And so I just kind of wanted to give that as a tip as you get started in the work. And I have the quote here: first, do no harm. I mean, we're talking about patient safety efforts here, which, you know, as always, it's the impetus of our treatment is to first do no harm to the patient, and no one should be harmed by a medication that is being given as a treatment or as a cure for our patients. So this is an example that I was going to walk through for hypoglycemia specifically. We don't have time to go through all 3 of the drug classes to talk about the interventions, but I'll actually skip over these slides and come back to them, because I wanted to start with kind of like the steps, like what is it that, where would you start? And I think the most important step in getting started is making sure you have institutional and leadership support for the work and that they're bought into it. And I believe that probably all of you that are participating here, your hospitals probably have signed a charter or agreement with HQI, and you're involved with CalHEN. You're probably providing them data on other types of harm. But it still is worth mentioning that we need to know that our leadership is bought into driving reductions in adverse drug events and making a strong case for that. And then once the leadership is on board and you have support for the organization to do this, it's important also to establish a multidisciplinary team. So don't try to do this by yourself. And another thing is the team needs to be led. So we can't just kind of assume that someone else, like the quality director, should be the leader, so I'm not going to do that. Or it really should be, you know, our patient safety person. That should really be the person, so I wouldn't do that. I would strongly encourage you to just take accountability, especially if you're a clinician and especially if you're a pharmacist, to take accountability to form and lead the team, regardless of what your position is, if your leadership is able to support that. So again, so making sure that you include, of course, physicians, pharmacists, nurses. Now, the things I have in parentheses here are examples if we were talking specifically about hypoglycemia. So depending on which adverse drug event you're tackling, you would want to include perhaps unique groups within, as our previous speaker was saying, they had to include anesthesiology as they were looking at naloxone usage in the emergency department. So for hypoglycemia, it would be important to engage with dietitians and diabetic educators that are on staff. Okay, so you formed a team, and the team needs to have clear accountability for reducing that type of harm. So for reducing severe hypoglycemia, for example, everyone needs to know that's what the team is for, that's what they'll be doing. Every month this team should gather to monitor the adverse drug event you're working on. So for example, severe hypoglycemia, and identify areas for improvement. There needs to be a physician champion involved so that you know you have buy-in from the physicians and that you have someone pulling for the cause in the physician world. And of course, monitor progress on implementing whatever interventions you decide to implement based on the gap analysis that I shared earlier. And so, for example, for hypoglycemia, you would want to monitor progress on the actual severe hypoglycemia rate. You should be able to track that and trend it in a run chart every month. And then track your progress on the intervention of, for example, eliminating sliding scale insulin and standardizing, hypoglycemic management protocols. Okay, the next thing would be, as you formed your group, you've got leadership support, you formed the group, you need to really start to understand what some of the gaps might be that are causing ADEs in your institution. So there's always going to be a couple of low-hanging fruit in each of the areas, but I think that at the end of the day, we each in our own hospitals need to kind of think about, okay, well, what are some of the problems that we might be seeing here? The gap analysis can help with that, by the way. So an example for hypoglycemia is trying to figure out what is the right timing of administration of insulin that is administered around the meal related to the delivery of the actual meal tray. And that would require collaboration with dietary services and figuring out how they currently deliver the meal trays, and then how you could potentially create visual cues on the trays that belong to patients with diabetes because they need their tray in a more timely manner. And then, of course, these are kind of no-brainers, but you have to implement your interventions, whatever intervention it is that you're working on. This is where I think it's kind of the tough work is actually, you've identified an intervention, you need to implement it. You might implement, for example, a standardized hypoglycemia management protocol that we talked about, including a process where the nurse can check blood glucoses without needing to wait for an order from the physician. And then also another intervention, basal bolus insulin protocols, and then eliminating the use of sliding scale insulin, which no one should be using sliding scale insulin. And then an important thing, we heard this actually from our last speaker, is to provide education. It's not very helpful if your group creates a really awesome, new, nice protocol, and you even get it published as a policy, and no one's using it. It doesn't help. We need to make sure that staff are educated and that they're using it, and then that we're transparently sharing data. I love when I go to a hospital unit and see each unit tracking one chart, in the nurse's station that kind of shows, here's our rate of hypoglycemia this month compared to the last few months or this week. If you share that data with your frontline, really engaged frontline providers, they will become accountable for that data as well. But if you only look at it behind closed doors in your, meetings with your folks that are on the group leading the team, or the team that's leading the work, that's not helpful. So it's important to be transparent with the data, both up and down, right? Reporting up all the way to leadership, and also reporting down to frontline staff and engaging them and owning that data and being a participant actively in figuring out how to drive those numbers down. I wanted to kind of share this example of, you already saw a beautiful run chart from MLK, so that was encouraging to see a hospital showing improvement. But you might have thought to yourself, "I'm so low, they're only having 1 or 2, events a month. It doesn't seem like that was that hard to do." You might have thought that to yourself. So I kind of wanted to address that by sharing data that's been aggregated from 35 hospitals throughout California, and that is from the Dignity Health system. So Dignity Health decided to own and take accountability for hypoglycemia across all 35 of their hospitals, not just in one hospital. And so what they did is they created 3 kind of key interventions, and they worked with each of those hospitals on implementing those key interventions. And then they started to diligently track and trend their blood glucose levels. So the rate is blood glucose less than 40, and the denominator being all point-of-care blood sugar readings. So you can kind of see what happened here. They had a very significant decrease. It was actually a 51.7% decrease from their baseline period to the end of the measurement period that I have here. And by the way, it's worth noting that that was in less than a year. I mean, that's amazing. So it didn't take them years and years to implement this work. This is rapid cycle improvement, where you select a measure, you measure it, and you quickly implement those interventions for driving improvement. These are low-hanging fruit, which is kind of exciting. And I wanted to share, if you are just getting started in improvement work, I doubt that's true. I have a feeling the people that are here, you guys are probably the ones that have done some of the most impressive work over the past 2 or 3 years in driving down different types of harm. But I just want to say ADEs is kind of a good low-hanging fruit in terms of improvement. And the reason I say that is I showed you the slide with the data from our CalHEN 1.0 results. ADE saw the greatest drop, which means that the interventions that were implemented had a great improvement or great impact, more so than any other type of harm. So I think that's something kind of notable to keep in mind. So Kim, I'm not going to go through the slides I skipped over on hypoglycemia, because I think I'd rather kind of engage with a discussion here with the folks that are here and try to be helpful in terms of understanding, first of all, does your organization's leadership support your work in reducing ADEs? And if they do you have a team that's put together? This question isn't up here, but do you already have a team that's put together that is working on and focused on reducing ADEs? And do you know what your ADE rate is for each of these 3 drug classes? Are you currently gathering and tracking and trending those numbers? And what other kinds of issues are coming up for you in this work? So with that, I hope that the list of items was useful to you. And I really hope that you might take a look at the Minnesota Hospital website. They have some pretty exhaustive resources up there, but if you look at nothing else, I would at least just look at the gap analysis, and then if you identify areas that you want to develop interventions for, then you could look at their website. They actually have resources in each of the ADE topic areas, so you can kind of choose where to go. So Kim, I'll turn it back to you. I'd love to hear from folks. I don't see any questions in the chat box, but I'd be really interested in hearing any comments or reactions from people on the line.
Thank you so much, Mary. And I agree. I would love for folks that are on the line to please type into the chat box here. First of all, how your leadership is involved in this work. Is it simply by supporting a team getting together, or are they actually involved with that team? And would like to hear what the, if you could also chat in the biggest issue that you have right now in your organization in terms of the data piece, because again, that is one of our top issues here. And while folks are getting an opportunity to type in then too, Mary, I just wanted to really thank you too. I appreciate you bringing in real, just the practical tools here too, and I think that's what this is all about. So getting folks to check out the Minnesota, I think I have to go back to it and make sure that I have it typed in correctly, but the Minnesota Hospital Association website too for that. And I know there are a couple of other resources too that we will make sure that we make available. There's another one in terms of opioid use too with the Pennsylvania Pharmacy Association for finding out, you know, the issues with opioid naive patients and all of the types of ADEs that occur around there. And there are lots and lots of other resources out there, and so we want to make sure that we get all of those to you, because that's what this is about. It is a very quiet group today, too. We don't have any questions being typed in, and that's fine. But know that, like Mary said, I do think that probably the folks that are actually on the line today are those that are really doing the work. I do see that some are typing right now, too, so that is good. And Mary, if you wouldn't mind just typing into the chat box again or actually, because I don't want to go back through all of the slides here, if you could type in the Minnesota website in there, so it's right there in the chat box for folks to be able to pick up there. The slides with all of the resources, thank you very much, Mary. The slides with all of the resources will be available within a few days on our website, so everyone will have access to that. And at the end here, too, I'll also show you the resources of the change package that's available at the national level that does have quite a few of these same resources available. Let me see if I can take that. I think that's the next page here.
So Kim,
yeah, there.
You know,
yes.
One of the things that I'm kind of taking away from this is it sounds like I think the measure slides that you presented would probably be so helpful to this group, because most people didn't raise their hands when we said, who knows how you're doing in ADEs. And so I think that's like, you know, step number one, like things to do by next Tuesday is you know, go find that data. It's not hard. It's just like you said, it is, you know, we live in a very data-rich environment in our hospitals these days. So whether it's through an EHR or whatever medical records you guys might be using, you should be, or maybe through the pharmacy system or the lab system, there should be a way for you to get that data, and it wouldn't be difficult to track it down. There's someone in your hospital that could get it for you very quickly, a monthly report run, or even a weekly report run, or even a daily report run if maybe your intervention will be a pharmacist actually conducting rounds on those patients.
Right.
So anyway, I'll turn it back
and I
to
see
you.
that, and you're absolutely right too. And you know what? There's also, Sandy Trotter just brought up a really good point, that her hospital leaders don't see ADEs as an issue of concern. They seem to respond to the HAC, the hospital-acquired condition measures, more. And ask, you know, to know when these ADE measures may be added. They actually are all part of the same measures in the eyes of CMS, Sandy, but I think this is an area too where then getting our leaders engaged in understanding, and not just the leaders, but everyone else, because this is probably an issue for leaders, for frontline staff, for others who, if the data hasn't really been all that available to them, they may not actually realize just how much damage is being done as a result of ADEs. And this is a great one where we can use that, the harm calculator or the improvement calculator. It's gone by a couple of different names for a variety of reasons. You could use it in one way to show the improvement that's happening across, but it does also calculate harm that has occurred. While the dollars associated with that harm is not necessary, you know, can be different at every hospital, and that may not be what moves folks. I think understanding the consistency with the sheer volume of ADEs that really do occur in our organizations, if we're getting the data appropriately, you know, if we're really mining for data and getting it, then we can get we can get this information. And Sandy, I see she's clarifying that she means in terms of reduction in reimbursements. Yes, I do not know if ADEs will be added. I think you're talking about like value-based purchasing and that piece there too. I don't know if that is going to be a piece. I do know though that the medication harm category is one that hits the news on a regular basis. So in terms of reimbursement piece, it's not straight reimbursement, but it does get the hospital highlighted when the larger events occur. And then there's the addition of, in California, what we have with CDPH, and if it's a significant event, that there is, some reimbursement, not through CMS, but there are, damages, financial damages that way. But, I think it's more a matter of showing how the sheer volume of this and what this actually does, what this costs to our patients, not in dollars, but in, more time spent in the hospital and all that will bring engagement from our leaders. And then, let's see, Mary, do you want to discuss Lynn's comment then too?
Yeah, sure. Yeah, Lynn was asking a really good question. She said, she's been working with hospitals that are used to reporting ADE by doses given versus by patients. So they struggle with the rates of reporting through the HEN. So my response to that is really I don't think the effort it would take to try to know, like, let's say for hypoglycemia, let's say you check a patient's blood glucose 20 times in a week, trying to figure out, like, how many times that patient was hypoglycemic, it's not really useful to your improvement effort. But if you can just track all of the readings that were less than 40, and the denominator would be all of your point of care readings. So if you did 1,000 readings that week, even if it was only for 5 patients or whatever it might be, don't worry about it. Don't worry about how many patients there are. Simplify. We can still drive quality improvement just by looking at the number of readings and the proportion of those readings that were low. And I think the same could be said for anticoagulation. It doesn't matter how many times we check the patient's INR, and checking to make sure that these 6 INR levels that were all high are all related to the same patient. I mean, at the end of the day, that kind of specificity is, scientifically, you would try to make it perfect and say we want it to be by patient. But in terms of quality improvement, it's not helpful. It's a waste of resources.
And I mean, to clarify, I know that for our actual HEN data definition, it's by patient, but when we're talking about doing the actual work of quality improvement, that's where getting, you can get a lot more out of your process measures and out of, figuring out what's happening in the process by looking at dose by dose by dose here too.
I was going to scroll up to your slide on anticoagulation to see when you say number of patients with high INR.
Number of patients on this one.
Yeah.
And that's just, by the way, what we have to go through right now for how CMS is defining it. And, as we go further in the future, I don't know if they're going to make some changes to clarify some of these definitions. I think that would be very helpful. I know that a lot of hospitals have been asking for that, and that would certainly help here. But for now, we're stuck with that one. But, again, that's not the only way that we can do quality improvement here. We are now at the top of the hour. Yes, go right ahead.
Oh, I'm sorry. This is Martha. Just a quick comment because I don't have access to type in. But one of the things, ADEs very closely relate to readmissions. So that it might be where you can help to pull in your leadership, because we know that a good percentage of the readmissions to the hospital are related to problems with medication. So I just wanted to throw that out there.
Very good point. Yes, no, I'm so glad that you said that, because that really, that's very, very true. And I think what we're, in terms of the 3 different drug classifications, I want to say that warfarin is one that we're seeing a lot more of the readmissions related to medication are associated with, although the other 2 are probably right there with it too. But no, very good point with that.
That's 100% true. I'm so glad that you said that. And that's actually the big thing I work on here at HSAG, is trying to reduce ADE-related readmissions. It is a big deal. I mean, I have so much Medicare data that I could tell you about, but I know we're out of time. But ADEs really, really drive readmissions. So
And
I'm
that
glad you mentioned that.
actually is a great segue into talking about what our next webinar is going to be working on. Actually, on August 4th, save the date, we will be talking about readmissions, and I am positive that we will be talking at least a little bit about medications and their effects on readmissions too. So, and that's not the only time that we'll be talking about these two topics together because they are so closely linked. So glad that you said that. I'm going to go get this back down to the very end here if I can so that you have the information for resources. Again, the slides will be available very soon on within the next couple of days on our website. You can always contact any of us. You can contact my email is here too, so feel free to contact me with any questions, and I will make sure to get them to the right people to get your questions answered. So with that, thank you so much for joining us, and have a great rest of your day.
Conference recording stopped.